Sir, we are live now. With all your permission, sir, I am starting this webinar for today.
Are you recording?
Yes, sir, recording will be given, sir. Sir, with all your permission, sir, I am starting. Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants, esteemed faculty, colleagues on this webinar. And today's session is very much important. The topic for today's session is India at the rate 100, diabetes care through evidence, partnership and professional leadership. As we move towards century of independence, diabetes continues to be one of the most pressing health challenges of our nation. This session will highlight how evidence-based practices, collaborative partnerships, and strong professional leadership can shape the future of diabetes care in India. So without any further delay, I would like to invite host for this webinar, none other than Dr. Amit Gupta, sir. And let me share some of the achievement of sir. Sir is the National Executive Council member of RSSDI and chair of the IDF School of Diabetes and secretary of Global Advisory Council of American Diabetes Association. His expertise and leadership make him an ideal for host for this thoughts-provoking session. So without any further delay, I would like sir and hand over this session to sir. Sir, stage is from here.
Yes. Thank you, Faraz, and thank you for organizing this session on India at 100 and what do we want to see when India is celebrating its 100 years of the independence in 2047. We all know that diabetes, global burden of diabetes is rising. At the same time, the number of people living with diabetes is rising. More and more newer therapies are coming out. Still, we are not able to to tackle this problem in a major way. So we recently published an article, and it was authored by Dr. Anuj Maheshwari. I was in a co-author, and last month, are all the patrons and the past president of the RSSDA. They met at the New Delhi, and they discussed that going forward, what should be the future and the vision of the diabetes care in India. So we thought that yes, it is very, very important, and we compiled our thoughts and we tried to put it into a piece of paper. You can say it is a kind of mini review. And first of all, let me welcome all the esteemed faculties today. Dr. Vijay Vishwanathan, sir. Dr. Vijay Vishwanathan is the president of the RSSDI, and he is a well-known figure in the field of diabetes as well as with us, we have Dr. Anuj Maheshwari. Dr. Anuj Maheshwari is the president-elect of the RSSDI for the coming year. Professor Dr. Vinod Kumar. Professor Dr. Vinod Kumar, is the founder secretary of the RSSDI, and he is the emeritus patron of the RSSDI. We have with us Dr. P.V. Rao. Dr. P.V. Rao is again one of the leaders in the field of diabetes. He was the secretary of the RSSDI for a very, very long time, and he also was the past president of the RSSDI. So welcome, P.V. Rao, sir. I welcome Dr. Muruganathan, past president of the RSSDI, and he is a mentor and he is a leader in the field of diabetes as well as the world of the hypertension. Dr. Panikar, sir. Dr. Panikar, sir, we all know is another thought leader from India, and he is the past executive council member of the National RSSDI. He is a global leader in the field of diabetes, and his ideas are very insightful. He often talks about very simple things which can which can help our patients in improving glycemic control. And none other than we have our own beloved Dr. Professor Shashank Joshi, sir, who is Padma Shri awardee and the past president of the RSSDI. He was the he is the president of the RSSDI at a very young age, almost 15 years ago from now. So welcome, Shashank Joshi, sir. So before we proceed for the discussion in this panel, I will request Dr. Anuj Maheshwari, sir, to say a few words and then start.
Amit, if you permit me, after Anuj, let me give the talk because, as I told you, I have another 2 meetings.
Yes,
so
sir.
I'll give my views and then.
Yes, sir. Yes, sir.
Yes.
I
Dr.
will
Muruganathan, kindly mute yourself because some outside voices are coming. Thank you, sir. Thank you, Amit. And I must give a bit of the context of this article which has been published, and we could be able to make it at the 79th anniversary of our freedom. It has actually been inspired by the idea which has been listened by many of us in our Prime Minister's speech, that what would be the shape in the 2047 of our India. In the same way, we thought that what would be the level of diabetes care in 2047, which is not very far away, only 21 years away. And then we started collecting data, started collecting evidences, what we have already achieved and what is yet to be achieved. And we collected that in a form of the a small mini review article, which could be published in Medcrave Journal. And I believe that we can really have many of its extension. So, but before going for the context setting, I must present few points of this particular paper, which has been recently published on 19th of August this month in Journal of the Medgrave, which is entitled that India at the 100, Diabetes Care Projection Through Evidence, Partnership, and Professional Leadership in next 21 years. So, which is a Vision 2047? What is that exactly? India's centenary in 2047. We are going to complete 100 years of our freedom. But what really we have achieved at the health sector? Of course, it is not a small thing that we could be able to increase the life expectancy of our countrymen. This is not a very small thing. This is a big achievement. We could be able to extend our health facilities in all sectors of the country. And of course, South India has fared much better in this than rest of the other parts of the country. So we especially synthesize the data to identify trends, implementation, experiences, and opportunities aligned with India's 2047 health system vision. Narrative synthesis of the epidemiological data, which was based on the IDF 2024 declaration, as well as the INDIABS study, which has recently been published in 2 years before by Dr. V. Mohan and his team. Indian and Global Prevention Trial, and IDPP, Indian Diabetes Prevention Trial, Kerala Diabetes Prevention Trial,
Anuj sir,
Darkwing, Finnish DPS, and government program reports has been the base of all this, what I'm going to tell you and what has already been published. Sources identified through targeted searches of the PubMed, Scopus, official government portals, publication from the professional societies like RSSDI and Endocrine Society of India. Selection emphasized studies and import with clear methodological descriptions, robust data quality, and relevance to India's long-term diabetes care strategy. Data were synthesized to identify trends, implementation, experiences, and opportunities which were aligned with India's 2047 health system vision.
Anuj sir,
So currently we are having
Anuj sir,
89.8.
screen is not visible, sir. Sorry for interrupting you.
Pardon?
Your
Are
screen
you
is not
sharing
visible.
slides, Anuj? If you are sharing slides,
Acha,
we are not able to see your slides.
slides are not visible.
Yeah.
You
Okay,
share,
You
sir.
are visible. You are visible, and your talk is very nicely heard.
Okay. I got this point. So I think now it is visible.
Yeah.
Okay. So we all understand it very well that current burden of the diabetes in our country is emphasized by the IDF Atlas is 89.8 million adults are living with diabetes, which are around 10.5% of the total adult population. As per the ICMR INDIAB data, it is a little bit more. 101 million people are suffering with diabetes in India, which constitutes 11.4% prevalence of the total population. But 43% of them are undiagnosed. This is the hidden epidemic across the country, and 3 times economic impact is coming up to prevent the complication, and especially the people, those who are facing the complication because they remain undiagnosed for a longer time. These 43% are putting up 3 times excess economic impact, not only on the government, but also on their own personal pocket also. So vision is that really could we transform the diabetes from a symbol of gaps to one to reform by 2047? 100 million and more than that, in fact, adults with diabetes in 2024, 43% undiagnosed. For 4 anchors has been identified for transformation, which were measurable in 2047 and could be targeted. Our emphasis remained on the evidence, partnership, professionalism, and equity to create sustainable change across the India. So if we look for the diabetes in India is not simply a clinical condition. It's not simply a disease which some people can consider it as a, but actually it is a mirror and magnifier of the rapid democratic and economic transition which we could see in the last 50 years and more in the last 30 years. That magnifies the systemic gap in the healthcare equity. India's centenary in 2047, lot of things has already been done, but it is biggest question, can we really fill this gap which has been developed because of the rapid demographic and economic transitions, or we can say rapid progression or rapid progress of the country on the economic and other platforms. The geographic reality is that urban-rural difference is getting shorter and shorter. It is going to the converge. Diabetes is becoming a nationwide challenge. Earlier, it was considered this is a disease of the urban only, but now it is extending its legs in not only in semi-urban but also in village population also. For the same, RSSDI is pledged to start the rural outreach program, which has been already designed and multiple states have already started it. The convergence of the urban and rural diabetes rates requires a unified national approach to prevention and care. What is the important things, or what is the unicity of the diabetes in India? One, it is earlier occurring, at least a decade earlier occurring than the rest of the world or Western countries. Even at the lower BMI, people are suffering with the diabetes in India. So lean diabetes is very common. Diabetes because of the undernutrition, that may be diabetes because of the FCPD, undernutrition. Many a times it could be a simply lean diabetes. Not always it is type 1 diabetes, but many of the time insulin resistance is rising in the people, those who are not gaining the weight. Accelerated complications and long duration of the disease is another challenge which is faced by the Indian population because of not detected their disease for a longer time. And even when they get detected, they stop the treatment in between, just thinking that once that glucose value comes down to normal and they think that their diabetes has already been cured. A lot of alternative systems of the medical treatments are also running in our country, which are also interfering with the treatment, and many a times they are scientifically directed or sometimes they are not scientifically directed. So at present, the 24.8% people are achieving only the glycemic control, which is recommended by most of the organizations of the world, that is HbA1c less than 7. 18% people are present with diabetic retinopathy at the time of diagnosis. This is the data of the CURE study. High rate of the complication at presentation highlights the critical need for earlier detection and intervention. A significant delay is there between the onset and appropriate management. Therefore, Indians are moving faster towards the complication. Many a times our people start developing their kidney involvement, renal failure in their 40s or 45 also. There is certain gender and social dimensions also which is to be inquired about. The women are underrepresented in diagnosis and treatment. Caregiver burden mainly on the women. Gender, social, and economic barriers are there which are impacting the access. As far as the women are concerned, we are having lesser access for them about the diabetes care. Gender and social inequities create significant barriers to diabetes care that must be addressed for the comprehensive reform. So lesson learned, what has really worked by the Indian Diabetes Prevention Study or Indian Diabetes Prevention Project, that says that 28.5% reduction in diabetes incidence could be achieved simply by lifestyle changes. Kerala Diabetes Prevention Project has supported this, and they have also involved many of the people in their states, and they worked in the community, and they have scientifically proven the thought that intensive lifestyle modification can take back the pre-diabetes to the normal living of the individual without diabetes. Nationwide, discrete level of the NCD clinics is there. In some places, the NCD clinics are working good. Some places, they are not really working up to the expected level. Ayushman Bharat is expanding the primary care, but there is still a gap between the primary care and the tertiary care, which is yet to be filled. And these successful programs, which are already running in various parts of the country, are actually evidence-based models that can be scaled nationwide. Technology that innovates the working function like mobile diabetes, telemedicine has really improved and it has really reached the experts to the distant parts of the country. It has in India only 4,000 experts are available against the need of the 21,000 experts. These telemedicine is the only thing which can take the 4,000 experts to all those who are needing these 21 or 22,000 experts. Teleophthalmology accelerated by the COVID-19. Digital health records framework is under the development. Still, majority of the physicians are not using the digital health record system, and it is yet to be encouraged in our system. Technology has proven to be powerful enabler for expanding diabetes care access across the country. But as I already said, we are preparing very good program at the grassroots level. We are having a excellent tertiary care in our country. And tertiary care is of the level that even we are promoting the medical tourism also for that tertiary care. But unfortunately, there is a gap between the grassroots programs and the tertiary care. People are not really getting a good primary care. People are not getting the good secondary care. District hospitals are under-resourced for the diabetes. Primary care physicians are lacking the enough education. Diabetes educators are not really there at the primary health care centers, and primary health care centers are not having the minimum informations and the facilities regarding the diabetes care. And many times the government provides the facilities also, but without information, they are waste. I can simply share one line, my one experience in Uttar Pradesh last 5 to 6 years before. The government of Uttar Pradesh has provided the analog insulin to all the primary health care, but that has not been utilized till the 1.5 year or 2 years in the lack of information to the doctors. Those who were posted there, they were not knowing where to use that, how to use that, and who are the right people in which they can use that. So until unless the awareness, information, and diabetes education is not being spread up across the country, even to the healthcare professional, is not going to help us. The anchor one is the equity. Essential diagnostics, treatment access, and transparency is not available equally to all our countrymen. Putting equity first ensures that all Indians, regardless of the location, socioeconomic status, can access quality diabetes care. Another anchor is the life course prevention, where we can really tell about the lifestyle modification and should be promoted since from the beginning of the life. I say that even the preschool age, even from the womb, we should start promoting the lifestyle modification. Of course, it should be continued at the workplace, gestational care, elderly care. Dr. Rajiv Chawla is there. He will be telling us about the gestational care. How can it be really improved and really be improved in this course to reduce the ultimate prevalence as well as prevalence of the complications for the diabetes. A life course approach integrates prevention, management, and complication care at every stage of the life. In our efforts in the last 79 years of the independence, we have increased the life expectancy of the Indian population, but that life expectancy has created a lot of new problems like Alzheimer's disease, like dementia, like forgetfulness, frailty, fall, and sarcopenia. So these things are really to be addressed in the new system. Technology and AI integration is the third anchor. Connected devices, CGM, smart pens, digital screening, mobile health platform, all support risk prediction and AI support risk prediction means artificial intelligence, how can help us in predicting the risk and personalized care. Fourth is the clinician public health. How much the clinicians are aware about the health not only of the patient, public, as well as their own health, is also very much important for them. The professionals as an architect of the protocols, audit, training system, which can give the public health programs, leads chronic disease management, ASHA and ANMs workers to be trained for a wider reach, and convergence of the clinical expertise in public health system creates a powerful framework for nationwide diabetes care. Professional societies at the catalyst works in our country. Can they catalyst work in the country? And they are actually doing this work. Capacity building by the RSSDI ESI kind of the platform. API is also doing the tremendous work. Training accredited physicians and allied health professional training is again being provided by these organizations, and implementation science and quality indicators is also important to measure the progress of the efforts which are being done by these organizations. Professional societies like RSSDI, ESI serve as catalysts for transformation, driving standards and innovation in diabetes care. So society functions like a learning system. Societies drive training, accreditation, and research. Shift from the academic conveners to the implementation partners. Doctors simply may not be, and teachers or medical teachers are not simply may not be the academic conveners. They should also be participating in the implementation, standardizing the care, and fostering the policy dialogue among the population, among the physicians, among the caregivers. Capacity building framework could be done by the physicians, like standardized diabetes management training they can provide. Educators, diabetes education, those educators, those who can give the patient education, and nurses, like specialized diabetes care skills they can provide, and they can be trained for those specialized diabetes care skills. As far as the dietitians are concerned, they should be trained for the nutritional counseling, and pharmacists for the medication management training, and they should also be trained for that which medicine is to be taken before the another medicine, and which medication sequence should be followed by the patient. The guidelines and quality indicators, which are the measurable benchmarks, and they can be developed by the societies, and they can be used for a monitor. Measurable benchmarks, which has the emphasis on the screening and glycemic control, and in fact they can play as a quality indicators for the foundation of continuous improvement in diabetes care. Registries and research infrastructure, as the RSSDI has already done, and our RSSDI is working in that direction. We have started many registries, including the Save the Feet, including the BP challenge in the diabetes patient, and many others also. We are also collaborating with the ICMR and ABDM. Data-driven improvement like national quality improvement initiatives are also under the way. Robust registries and research infrastructure will provide the evidence base for the continuous improvement in diabetes care. Policy partnership framework evidence are being amplified. Amplification of the evidence in policy planning and government programs. The evidence which are being generated by the RSSDI, real world data which are being generated by other societies also, they could be helpful for the government policy making. Ayushman Bharat rollout, NPCDCS has supported it, and advocacy is the most important part of any organizations to be roll out, and it could be for the resources and accountability. A structured policy partnership framework ensures that clinical expertise informs the government program and policies. So global leadership vision, India as a global model, regional collaboration with the IDF, WHO, Southeast Asia, multiple organizations in the Southeast Asia, sharing India's model with the low and middle income countries, export innovations in the care delivery and technology. So there is the innovations which are being developed in diabetes care across the world, but India is a bit different than rest of the world. We need some different innovations. We need some things which are not really working for the Western population and American population. Our needs are a bit different, and that's why 2047 targets is the awareness more than 80%. Diabetes awareness among adults should be 80%, and this should be achieved through the mass screening, health education, monitoring in the regular population, which is based on the surveillance. 2047 target 2 is the glycemic control. More than 60% people should have their HbA1c less than 7%, which is currently 24.8%. It's really very less, and difficult target to achieve, but of course, the targets are to be difficult, then they can always be achieved. 2.4 times improvement is needed to achieve these targets to reach the from the current level. The focus area should be the medication access, comprehensive management, patient education, and third target is the complication prevention, which is the biggest target because people are dying because of the complication. Half rates of the amputation and half rates of the blindness should be the goal for the 2047. Universal access to the retinopathy, food screening, prompt treatment of the identified complication, coordinated management of the retinopathy, foot disease, and renal complication. That should be a part of the integrated care, and that should be the goal for the 2047. Fourth target should be the kidney. Protecting kidney functions through early detection and aggressive management will significantly improve quality of life, reduce healthcare costs. Fifth is the equity achievement, eliminates gender and rural inequities in our rural part of the country as well as in the urban parts of the country. That should strengthen primary care and outreach in rural areas. Primary healthcare center achieving equity in diabetes requires the targeted interventions to address the specific barriers faced by the women and rural population. Roadmap for the implementation 2025-2023 has already been known that we can have the foundation phase, building the infrastructure and workforce, develop the digital system, test large-scale pilot. The foundation phase will establish the infrastructure, workforce, and evidence based on the need of nationwide scale up. So now we are looking for that 2047. How should the roadmap be going? And implementation of this 2031 to 2047 should be a scaled proven program nationwide. It should be quality improvement initiative. International collaboration and leadership should be promoted, and it should not be on one sided that we are accepting their something from this collaboration. That should be the bilateral, not only accepting but also we are contributing in the progress and treatment as well as in their prevention of diabetes in other countries also. The scale of phase will transform India into a model for diabetes care system globally. So call to action: shared responsibility with the government, communities, societies, and healthcare providers. Thank you very much. We stand together. Together, we are the difference. We can do the difference by 2047. And I believe today's discussion shall definitely be not only meaningful, but it will be the roadmap for our next generation, those who are coming with us as well as after us, to take this baton. Thank you.
Uh, Thank you, Anush Maheshwari, sir.
Thank you very much, Anuj. It was an excellent, exhaustive. Sorry. Go ahead. Amit?
Yes, sir. So thank you, Anu sir, for excellent presentation and bringing the vision document and for the discussion with all the esteemed panelists and the faculties who are all stalwarts in the field of diabetes. Dr. Vijay Panikar sir has a talk to deliver at 9, and Dr. Muruganathan is also in the travel. So if with the permission of the other panelists, may I first take the questions from the Vijay Panikar sir?
Amit,
Dr. Muruganathan, you can give.
Yes, yes, sir.
Dr. Muruganathan,
Amit, please.
he's already in the car.
Muruganathan sir, your voice is
Actually, I have only 2 points to say.
yes, yes.
Now, can you hear me now? Can you hear me?
Yes, sir.
Only one
Now,
point
now you're audible. Dr. Muruganathan, you're audible now.
Yeah, 2047, we'll have more of a primordial prevention of type 1 diabetes. I'm 100% sure there'll be no type 1 diabetes because there'll be definitely a preventive strategy will come, and precision medicine will come in a long way. And that will help us to even diagnose early. And also there'll be a lot of newer gadgets will come, and the management also will be full of drugs. So my feeling is 2047, we may not have this much of diabetic problem, and we will have more problems with very, very many other disease, not with diabetes. And in 2047, Anuj will be alive, and he'll be one of the leading scientists another 25 years. I don't know whether I will be there, but Anuj will be there. Over to you, Anuj. Thank you. Thank you for thinking about 2047.
Muruganathan sir, thank you for your nice comments and very insightful comments. And as you know, sir, if the problem is big, the solution has also be something to be out of box, so that and in long-term planning has to be done. So if you are with us, we will still take few more questions with you. But now I will move to Dr. Vijay Panikar sir first. Vijay Panikar sir, you have been working in the field of diabetes, and you have been a legend in the diabetes field. So I just wanted to understand, sir, what can be done at the grassroots level? How can how can we develop local networks and the regional networks which can improve the diabetes care and help us in implementing this vision? And first, your opening thoughts on this vision, sir.
See, first of all, you have to realize what the problem is. Dr. Muruganathan, can you just put it on mute? First of all, what we have to realize is the extent of the problem. It's huge. The diabetic population is huge. We are number one in the world. The amount of pre-diabetic population is even huger. And the kind of lifestyle which is there today in our country, with obesity going up very rapidly, with childhood obesity going up, with adolescent obesity going up, the incidence of diabetes is going to really double. So I think the first thing we need to do is how to prevent. Prevention is better than cure. And I think the government, all our agencies should work on educating people on lifestyle and what the problems are. I mean, it's something like there was the AIDS prevention program done by the government or the family planning program done by the government, extensive. And that is the kind of thing that is required for the country to promote awareness of the extent of the damage that diabetes can do and how we can prevent it. Prevention would be the key. And in that, lifestyle modification, obesity, diet, food, stuffs, all these things will come. As far as the future of, say, 20 years from today, I think the future is bright. The kind of research which is going on, you will have a lot of new things which are coming in, and hopefully, we might even find a cure for diabetes. I really wish and pray that that can happen. But the way things are, you will have automated systems, you will have glucose monitoring systems, CGMs, which will be much better, much longer, much cheaper to be used extensively by people. You would have genetic studies which can done, which can identify people early who are likely to be diabetics or prone to be diabetics. And very personalized therapies can be given for prevention and for treatment in the future. Even stem cell therapies and all these things are going to be there in the future. And I see the future is very bright because the way technology has come, you just see today, obesity at one time was a very difficult thing to really address. But with the advent of GLP-1 and co-agonist and the triple coming in and a whole host of drugs coming in, things are becoming easier to treat. And this is what I envisage in the future, that things will become easier. But I think our focus should be mainly on prevention of diabetes. That is the most important thing. And across the board, I think RSSDI, ESI, all the associations and the government of India should focus heavily on this huge epidemic, which is going to be a drain on Indian economy, health-wise, monetary-wise, and everything, if we can prevent it. So it is preventable. And that is where the crux of the matter is. All the technologies will come, but let us prevent it. That would be my take on this. Thank you, Amit.
Thank you, sir. And I completely agree with you, because if you need to prevent the tsunami of diabetes, you need to be ahead of the diabetes. You cannot be behind the tsunami and then wait for tsunami to pass. And you are right, this can only happen with the prevention. So before I go to the PV Rao sir and the Vinod Kumar sir, I will just ask one question to Vijay Vishwanathan sir. Sir, societies have a responsibility of academic education, and we are doing this beautifully. RSSDI is an organization which is more than 53-year-old now, and doing a lot of stuff. But what exactly can be done at the level of the societies to take this education and get it implemented at the grassroots levels? Because the standard of evidence it is not translating into the standard of practice.
Just 2 minutes, Amit, Dr. Amit.
Yes,
My
sir.
voice is waxing and waning. Morning it was very loud. Evening it's very low. So
You are not audible, Vijay.
no, uh, that's because the waxing and waning is in the voice. But I think RSDA has got a huge number of people, and Anuj is going to take over as a president, and from me, and we are very happy that he made a good presentation today. And RSDA has got 12,000 members, and it is acting. We can only act through the members. We can't act independently. We can only act through the members and go to the grassroots level. And the programs like the village adoption program, which Anuj Maheshwari's talked about very briefly, is going to be taken up in a very big way by you and by Anuj Maheshwari. But I think it's RSDA, ESI, which has to be the driving force for the implementation at the grassroots level, at society's level.
I agree with you, sir. And because nowadays these projects which are being initiated by the RSSDI, they actually they are meant to take the RSSDI efforts not only of the education but to see that it is actually implemented at the grassroots level. Uh, PV Rao sir, I have one question for you. I know you are one of the person who has been very fond of technology also, and you yourself is working on a lot of products and the projects, including technology and the AI. So I just wanted to know that we know that the AI is coming and a lot of things are coming like predictive analysis and how are they going to transform diabetes care? And second question, sir, I will also merge this with whenever a new technology comes, the question of the cost effectiveness comes. So how are we going to mitigate and adopt this cost effectiveness while adopting the same technologies?
AI is something is a new word, but basically we have been working with a lot of statistics and epidemiology earlier. So most of the AI what we are talking about right now is nothing but our regression analysis or correlation matrices. So when we have more and more parameters, we will have more and more predictive values, and prediction will be better with the more and more parameters. That is happening now. For example, if you take any genome or proteome studies, it is something like 30,000 to the power of 30,000 parameters are available, and we are getting more and more information, analyze it properly so that the prediction becomes better. So AI is a good thing that is coming up, but I think it will take some more time for us to depend fully on AI. We still have to continue with our conventional methods of physical consultations and physical biochemical tests and all such things. So it will continue, but in future, I think there will be a sort of something like genome. We'll have genomics or proteomics. We will have sort of other metabolomics also. We'll have some thousands and thousands of parameters coming from a non-invasive methodology, not just invasive, non-invasive, cheaper point of care methodology will come into. It's already there, but it has to be more practical and more adaptable to the society. So non-invasive point of care and multi-metabolomic approach will be there, and we'll have more and more information coming to us with a fingertip from this AI technology. A lot of innovations are happening, and some of us have been part of these innovations, especially with this non-invasive and point-of-care technologies in diagnostics. I have not done much about therapeutics, but we have some good first-hand experience about diagnostics. I think in future we'll have more non-invasive, cheaper point of care devices coming up. So that will fill up the gap. Anuj has mentioned that the 46% of the people are undiagnosed, and by the time they come to our clinic with the first day of diagnosis, they have 18% retinopathy. Most of the complications appear at the time of diagnosis. In India, almost anywhere, somewhere around 15% of the people at the time of diagnosis have small vessel disease as well as large vessel disease also. We know about this from UKPDS days. So that has to be tackled by this kind of early diagnosis. So I think in future there will also be AI from face analysis by just looking at the face, like what we are doing with all these people and all that kind of things. We will be able to diagnose diabetes and complications by just looking at a camera, and it should be able to. That is also possible because right now such things are happening with leprosy. I have seen leprosy patches being diagnosed by just Google Lens and mobile technology. So all these things will happen in near future, and we'll have better modalities to diagnose early and also start treatment very early. That's the most important thing. Most of the innovations are happening in the diagnostic part, which will help us in early identification and prevention of the complications. Secondary prevention will be possible with all these AI technologies.
Thank you, sir. This was very insightful, and I'm sure with the advent of the technologies, we are going to be stronger and stronger in dealing with this epidemic. Vinod Kumar, sir, I have a very interesting question with you. In 1972, when you founded RSSDI, diabetes was not even a disease in India. And you have seen the growth of diabetes, you have seen the growth of the organizations like RSSDI, you have seen the growth of organizations like IDF, ADA globally. So, what is the biggest gap which you find between the research evidence and the routine practice? Why the diabetes is rising faster than what we are learning, and why is it happening, sir?
I think good question. I think there is a huge gap between the research initiatives and the clinical practice, particularly the practice of the primary care level. And what I would suggest that in order to eliminate that gap, one of your anchors also says that there should be convergence between public health and the clinician. So this convergence is going to do the trick if we put it in proper perspective. And my feeling is that because I have some experience of working with the government departments for prevention of diseases, for health promotion at a very large scale. For example, we had a mandate to do the health promotion for all the rural people in the country within a matter of 5 years. Similarly, we had planned schemes for cataract eradication, which is another very difficult area. We had planned a scheme on telemedicine. We had planned a scheme on Poshan Abhiyan, that is food security for needy persons. So, what I would like to suggest that when you come to diabetes, firstly, I think one should realize that diabetes has got, from the gender differences apart, it has got three age cohorts mainly. One is children and adolescents. I am still talking of type 2 diabetes. Type 2 diabetes is coming in children and adolescents. Their approach is different. Then there are usual adults, and then there are elderly. The elderly people, if you take from 60 to 90 or 95 diabetic people, they have, although they are mostly what is called MARD, mild age-related disorders, but yet they, in the large number, they die of cardiovascular disease, including heart failure and stroke, etc. So that has to be taken differently. So I would suggest, in order to put the prevention into practice, we should find out and prepare some documents for caregivers. Caregivers are maybe nurses and maybe the health workers who are working at the sub-center level, what we call as Arogya Mandir, and we also have the clinicians, the primary care doctor. Let us dissect out these grassroots levels from the people like us who are having much more knowledge and we are able to disseminate information on larger platform. But that has to be percolated down in a manner which is easily understood by the grassroots level. And for doing that, capacity building is very important. And I would say that the three categories that you have mentioned about nurses, about the primary healthcare doctor, and also dietitian, for each one of these, you have to have simple modules, manuals containing modular teaching. We have prepared ad libitum many modules for paramedical workers, for doctors, for nurses, in terms of healthy aging. We have done it, and they are all printed by the Ministry of Health. So similar kind of modules should be prepared, although in a shorter form, for the disease of diabetes, and proper guidelines how to treat a particular diabetes should be engraved in those modules. And this is a subject that we did under the aegis of Systemic Health Research of the Ministry of Health. These people are very fond of, very expert in making the module with the help of experts. So number one is module. Secondly, these modules will be in writing. They will be in written material. You have to identify the trainers who could train these caregivers to increase their capacity building. These trainers have to be taken off from either district hospital or medical colleges to train. Now, these trainers for the caregiver, these trainers themselves have to be trained again. These are called master trainers of the trainers. So there are three levels of training. Master trainer at the top, good medical colleges, institutes. Then there should be trainers who could be from district hospital, taluka hospital, and in some cases, very well trained primary healthcare doctors also. But the trainees have to be these caregivers like dietitians, primary healthcare provider, and people who are there at sub-center level, that Arogya Mandir. So that is how you are going to uh, create a system of capacity building. And I don't think government will make any problem with regard to the budgetary provision, because this is very important. And here, in addition to the national program for the control of cancer, diabetes, cardiovascular disease, and diabetes, there is another program going on, which is called NPHCE, National Program for Healthcare of the Elderly. This is also sitting on the NCT base. The only difference is that there are more than 60-year people. Now, many of them are diabetic also. So they also have, they need educators, they need dietitians. So I think some kind of convergence can be done so that we can save some money. That is number one point. The second point is, I would like to again come back to a big segment of diabetic people. Again, I'm trying to draw your attention to elderly people. 60 to 90, they may be having 20% or 25% of them being diabetic. Now, what is happening? Although many of them, they are mild diabetes, mild age-related diabetes, but ultimately they, at least 50 to 70% of them, they succumb to cardiovascular disease. And they are more prone to get hypoglycemia, they are more prone to get hyperglycemia. But World Health Organization has identified 6 functions in the elderly people. These 6 functions, if they are detected early, and the detection is very simple, in 7 or 8 minutes, they can all be detected. And once they are detected, a primary care action should be taken, and regular checkup for these 6 functional declines to be taken, because these functional declines, like cognitive decline, like frailty or the mobility problem, like deterioration of vision, deterioration of hearing, or anxiety, depression, or nutritional problem, which is associated with vitality, unless you detect them, you correct them by primary action, or maybe later on referral system, you will not be able to give a good quality of life to older people, howsoever mild they may be. because these disabilities, they are always going to impede their medication taking, their exercising, they are taking proper meals. This is the problem, and they have vision and hearing problems. Not everybody has a very good spouse or caregiver who keeps complete, and neither the doctor has so much of time. So here it is the caregiver, grassroots caregiver, if nobody else is available, who would see to it that the elderly that an elderly diabetic is placed on the pedestal of these six deteriorations which are age related, which are progressive, which have been identified worldwide by World Health Organization. So that part we have to do it. That's number one. Number three point, which you have asked me the question, I would like to say that the health research in the field of diabetes, to my mind, it is misdirected these days. I think this is true for many sciences because anybody round the corner, any medical college, any hospital, he keeps on doing his own research. He presents the conferences, he publishes, but we have no idea that these multifaceted, isolated researches, how much good they are doing for the patients at large. So RSAGI should be a body to streamline the research proposal. They should put a guideline what kind of research is needed for topical interest in this country on a long-term basis. And other researches which junior colleagues come out with, they can be presented as paper presentation. But the research is very important to be streamlined and not Tom and Hick and Harry keeps on doing some collect data and then they just present and the time is wasted. That is one thing. And the last point I would like to say, because you have asked me about the policies about save the feet.
Vinod Kumar sir, I will take that question in a next step. First, I would like to, sorry for interrupting you.
Okay.
I will take one question from Shashank sir and then Rajiv Chawla sir. Shashank sir, this is a big question. Now, we know every
You're muted, Amit. Amit, you got auto muted.
Yeah, sir. So, uh, so first of all, thank you for joining this panel discussion. And I would like to know your thoughts on the paper as well as the vision. But one thing that we have been saying for last several years, and this has not changed, that the 50% of the people with diabetes are still undiagnosed. And if they remain diagnosed for years to come, then how are we going to tackle how are we going to tackle the tsunami of diabetes? So, what is your take on that? So, what should be done to bend this curve?
So I think, Amit, first of all, congratulations to you and Anuj. I think Anuj gave us a very huge holistic perspective from every level. Now, the biggest problem and challenge with diabetes is the hidden burden of the disease. Because it's a chemical disease, people don't know that they have it. And therefore, population-wide screening ke liye, in a country like India, we need Jan Andolan. Jan Andolan means a mass movement. See, we have 1.4 billion people on planet Earth in India living. Out of the 8 billion people on planet. So every, 1 out of 8 or 1 out of, 2 out of 8 persons on the world are Indians. In that, approximately 250 million, which means 1/4 of India, is probably having either diabetes or pre-diabetes. So I think there has to be a Jan Andolan. And I think there has to be a national need, but it has to be a mass movement from schools. That if your family history is positive for diabetes, or if your waist circumference is more than 80 or 90 centimeters, after 20, it is mandatory to do sugar testing. Unless and until we make sugar testing a mandatory thing, it is not going to be picked up. जैसे आपको आधार कार्ड चाहिए, जैसे आपको बैंक में एंटर करने के लिए आधार कार्ड और पैन कार्ड लगता है, वैसे आपको एक जन मुहिम and Jan Andolan has to be done where we have to do mass screening. unless and until we are able to get into a population wide screening program, because we are a high risk country, and the early diagnosis is actually prompt treatment will actually prevent money or economy from complications. So even from an economic standpoint, the biggest burden of the disease is treating. We are become tertiary care complication treatment doctors. And if you want to make a change and make a dent on complications, make a dent on diagnosis. See, the biggest problem is people are coming with a heart attack. Even now, 18-year and 25-year-old kids come with a heart attack with diabetes. We are getting people with kidney disease. First time in their life, they know they have diabetes. So I think this has to be a Jan Mohim Jan Andolan. We have to compliment our honorable Prime Minister. He has started obesity ka bida utha liya unhone. And I think he has taken up obesity very seriously even in the Independence Day speech. And I think we must now, from obesity, tunnel his gear into diabetes, so that diabetes is the silent emergency which is bankrupting India. Because who is getting diabetes? People who are socially moving the gradient and getting affluent. So they are in their most productive years of their life. And if we lose this working population, our GDP will be hit. So I think we have to sensitize all stakeholders, policymakers, government, non-governmental organizations like RSSDI. I appeal to Anuj that in his tenure, he really picks it up. Vijay has already done a lot on the Save the Feet campaign, and our previous presidents have done a lot of good work. But I think Anuj ji, aap please bida uthaiye, because the largest hidden burden of the disease today is from the state where you come from, UP. If you see the ICMR in-depth mapping, the next hub where diabetes will explode will be UP. In fact, in Tamil Nadu, it is plateauing, but in UP, it is supposed to explode. So I think we must pick up the hidden enemy in the population. And it's a silent disease. So it's a silent emergency. So jab tak we don't make it like a war, we will not be able to get this change happening. So I think, Amit, I appeal to you and Anuj that please pick this up as a Jan Mohim, Jan Andolan. And just like you ran a beautiful campaign for blood pressure screening and for Save the Campaign feed screening, I think once both of you are in the seat in Cochin as secretary and president, you will probably be able to do this in a bigger way and try to map India in a bigger way. So I personally feel that we need to do this. We need to, pick up, and it has to be regional, because India is not a country where one language is spoken. And it has to be at population level, and it has to start from school. See, there are two focus areas of prevention. One is the school, and second is the workplace, apart from the home. And I think in both these places, ISSDI should devise both screening and intervention program. I will not call them prevention, because prevention is intervention. And we must devise these programs. We will be more than happy to use. Then we can use technology. We can use many other things. And their ideas don't demand money. So even implementing this has to be a muhim. Just like if we could manage a Kumbh Mela, okay, we will have to do it at that level. And I'm very passionate about this entire subject. So I'm grateful that Anuj is making this presentation and he's getting out this white paper. And I think this white paper should sensitize all stakeholders. We should sensitize global stakeholders like WHO, IDF. We should sensitize all over the other sister organizations, whether they are diabetes or non-diabetes. And then we should sensitize our ministries, both in center and states. Because remember, policy comes from center, but the execution happens at the state. So there is no point of having a policy at the center which doesn't get executed at the state level. So I think it is important to sensitize stakeholders. It is important to do capacity building. But I think you made a very, very crucial point that this is the most important thing, is that we need to diagnose the hidden enemy. And I think the silent killer and the silent emergency needs to be emphasized again and again. So I think this is an excellent approach, and we can definitely make an attempt and a dent, because if we can stitch it at the nip it in the bud, I think we can make a change. And I think we have to be the change makers. So I once again congratulate all of you for this wonderful exercise. And I'll be happy to answer a couple of other questions. But I think as far as the hidden burden is concerned, it has to be Jan Andolan. And for Jan Andolan, if you want to do woman empowerment, this Jan Andolan is actually a national movement. For vaccines, it was used very well for COVID times. Similarly, we have Nari Shakti. Because remember, who is a decision maker of the house? Whether a blood test has to be done, it is the woman of the house. She will tell you, खाना क्या पकाना है और blood test किसका करना है. So therefore, you should ensure that there is Nari Shakti and woman empowerment, and we should make them also as a target in our intervention beyond workplace and school. So there are three targets for intervention. One is women, second is the school and colleges, and third is the workplaces. If we are able to target, then we can unmask a lot of disease. Because जब तक घर में माँ या बहन नहीं बोलती है कि जाके आप जांच करो, जांच नहीं करते लोग, या ये कम खाओ, एक्सरसाइज करो, कोई टोकने वाला चाहिए.
You are very right, sir, and thank you for sharing all the insightful thoughts. And this really helps, sir. And you are right that it has to be a Jan Andolan, and with all the leaders from the diabetes and each and every member of the diabetes community, whether not just the RSSJ but every other organization, we need to gel together, work together to take this forward. Sir, my question is in continuation with what Dr. Shashank sir has just answered, and this is with Dr. Rajiv Chawla, sir. First of all, sir, welcome for joining us from I know you are traveling and still you could join us. So my question is that even if we detect early, we are still going to deal with the people who are still living with diabetes. And we have given some projections in this paper that we want to reduce blindness by 50% by 2047. We want to reduce amputation by 50% by 2047. We want to delay dialysis by at least 5 years in people living with diabetes, those who are having advanced stage renal disease. So how do you see that, sir?
Thank you, Dr. Amit, and I'm really happy that this initiative have been taken on a big platform with all doyens of RSSDI and endocrine people joining this initiative. What Dr. Shashank very rightly said has to be a muhim. He very rightly said that getting an Aadhaar card or PAN card is important. Today, I think even for young adolescents, getting a health card is also going to be equally important when they are joining any corporate jobs or even government jobs. And I must share with you that we are part of IDF under the IDF domain, a prevention of obesity and metabolic problems in adolescent at school levels, and we are working with Professor Inash Sheltout and Dr. Peter also being part of that. And what I'm really appreciating that this initiative, like you did the feed campaign, you did the blood pressure. I remember immediately during post-COVID, along with Dr. Bansi, you have run a 10 lakh screening program for all those who were undiagnosed diabetes. Aim was to first to pick them up, diagnose them, start treatment, and then track them so that we could prevent complication. And that was a very tall and a very bold program which you were as a core member or a steering committee member, you were pursuing that. And today, I think there is a need. Early days, we used to say that it is only ABC. We were talking of only an HbA1c, blood pressure, and cholesterol control. But unfortunately, the entire evidence which has been collated over the years from our own country has told us that not even 30% or 35% persons living with diabetes, they meet the goal. So by 2047, I'm again happy that Dr. Vijay has run that feed campaign, and now with Dr. Professor Anuj Maheshwari coming, he has a huge rural outreach at his mind. Very good that he made this presentation, and he has already sensitized the entire RSSDI organization, the members. See, we have to partner. Neither government can do it alone nor any private agency. We need to partner it with the government, as Dr. Shashank said. Mr. Modi has already sensitized people against obesity. Similarly, this campaign has to go so as to reduce NCD. You rightly said, aim is to reduce dialysis by 50%, blindness by 50%, maybe amputation again by 50%. But what I see, I have been a past DIPSI president also, and still a very, very core inner group member with DIPSI. I am happy Dr. Anuj also has the same psyche, and we have been sharing those thoughts on different platforms, that in the coming years we adopt the principle or the national initiative of primordial prevention. Today, we talk of primordial prevention, that if we can intervene early at the stage of first trimester in a pregnant female, pick them early, treat them in a view to prevent hyperglycemia in them. In the long run, we prevent those offsprings getting NCD after 20 to 25 years. I remember in one of the DIPSI meeting with Professor Jitendra Singh, inaugurating that meeting, I made him a request, and which he agreed to, that we still have 20 to 25 years or 22 years till we reach 100 years of independence by 2047. So we have that opportunity if we intervene today by early screening, by adopting a primordial prevention program at the national level. Maybe DIPSI is our sister concern, RSSDI, join hands with DIPSI, and we make a bigger force. We tend to intervene early, prevent hyperglycemia in pregnant females, and in a long run to prevent offspring born out of hyperglycemia in pregnancy. So I'm sure there, obviously, their prevalence of NCD in those offspring is going to be significantly down. So that can be a huge step towards achieving what we today say, that within 100 years of independence, we might be able to ensure, maybe if not cure, but maybe a solution to reduction of NCD. So more and more people need to join hands. All agencies, maybe RSSDI, Government of India, maybe DIPSI and other bodies, we can partner with each other in carrying out these initiatives at the national level, so that tomorrow, in next 20 to 25 years, we might be able to curtail this progression of NCD in this country, because this is going to be otherwise a huge problem. Any number of hands will not be able to treat. Dr. Shashank rightly said, close to 100 million diabetes patient living today, and almost 136 pre-diabetes patient living today. You can imagine after 10 years, the number is going to be even larger for all of us to handle. So I think we must initiate today that primordial prevention in an attempt to reduce NCD in the future years to come.
Thank you, Rajiv Yawla, sir. And today this discussion is really going in such a positive note and positive direction that we are getting so many insights.
One more thing, Amit, I'm sure with you, Dr. Sanjay Agarwal, Dr. Anuj, having a common approach towards achieving these targets in an attempt to reduce NCD over the coming years, I'm sure with huge amount of manpower, and you people being not only at the core of that initiative, I'm sure this is going to be a huge strength, and I'm sure you people will be able to take it further over next 2 to 3 years.
Thank you, sir. And I will be mindful of everyone's time, because everyone is traveling. And so I will request Dr. Anuj Maheshwari sir to conduct the last round and take one last opinion from everyone before we conclude this session. Anuj sir, over to you. Unmute, sir.
Yes. Yes, I really heard the opinion of every expert, and in fact, I am thinking that we should organize such kind of the program more and more in the future also, so that we can understand what really is needed to do. One person cannot do anything. Neither Dr. Anuj, neither Dr. Amit, neither the people those who will be coming in the next generation for the RSSDI. It is always a uh, common and constructive approach by everyone. Once we shall be moving ahead together, then only we shall be able to achieve the target. Things are very lucrative when we say that India at 2047. But time is only left 21 years. And in this 21 years, our target is reaching from 24.8 to 60. As of now, only 24.8 people are achieving the HbA1c target 7. And we are thinking that by 2047, at least 60% population of diabetes having the target, achieving the target of less than 7. This is very easy to say, but how would it be possible? As you very rightly said that we always think that this much number of the reduction in diabetic foot, this much number of the reduction in hypertension, we aim for up to 5 years and next 10 years. But do we have really made a roadmap which will reduce this in a systematic, structured way? I'm really very much impressed of a project what Dr. Shashank Joshi has run, that is a twin healthcare. And this is a so nice project and which has really taught us that how to go step by step for the amelioration of the diabetes. And we have seen that a good number of the patients, those who were using the 3 medication, 4 medication, they have been off the medication with gradually reducing their glycemic variability. So this is called a stepwise approach. This is called a structured mitigation of the problem or structured amelioration of the disease. What we need to follow in next 21 years, and we are required to make a roadmap for that. And that roadmap should be not only of the RSSDI, that roadmap should be common for all Indians. And all Indians should follow that roadmap. It should start from the lifestyle measures. Kerala Diabetes Prevention Program has given us the wonderful insight that a lot of things can be done by the lifestyle modification. They have taken up the people, those who were keeping their HbA1c less than 6.5 but more than 5.8. And they promoted lifestyle modification in them, and they could be able to reverse a good number of the people, more than 30% and 28 to 30% people back to their normalcy. This has been the lesson from the Kerala Diabetes Prevention Program. This state has given us a insight which is really useful for the UP kind of the state. UP, where we are looking for the 15% people, those who are having the pre-diabetes. Our population is 3 times in the pre-diabetes than diabetes. India in diabetes study says that 4.45% are diabetes and 15% are pre-diabetes. How can we really handle this if these all 15% would convert into the diabetes, how would we handle the load of the patient? How shall it be handled by the experts? The given situation of the experts across the country is less than one-fourth what is the required. A requirement is around 22,000 or 23,000 of the experts, and we are serving only 4,000. So how would it be the such a big load could be handled? This won't be. This would be very difficult. So we need to make a roadmap. We at the one place we have to develop our capacity to handle the big load of the diabetes. On the other hand, we should try to reduce the burden of the disease by putting up the measures which can take the people back towards the diabetes people towards the pre-diabetes and pre-diabetes people towards the normalcy. And at the same time, we should try to make our own guidelines, which are really needed in our own perspective. We should not simply rewrite the Western guidelines, which has already been given. Many of the times we try to play safe. We do not want to take any risk. And in that situation, we think whatever the data is available, whatever the evidence are available, we can take them as it is instead of putting up any new effort. We need to do the new efforts. We need to place our requirement. We need to shortlist the requirements what the Indian people should have, and accordingly we should find the answers of those questions which we are having, which are very much different from the rest of the world. So this time I also kept the same theme in RSSDI 2025 Kochi, where I kept it as a India first. What are the answers which are very much different for the rest of the world, but for us they are having the different, and we are trying to find out the answer of those questions. So that's all from my side.
Thank you, sir. And it gives me a thought, sir, that when we are talking about any organization also, we should be having a long-term goal. So it is not just year to year, we just keep doing meetings and scientific CMEs and the retreats and all. At the end of, we should be having a defined goal. So what exactly we achieved after 5 years, what we aim to achieve after 10 years, 15 years. So the leadership should come together and not only think of as short-term projects, but the long-term goals of the society should also be defined, that as a body, what exactly we are going to do when we see RSSDI as a contributing, or any other organization like ESI, what we are going to contribute to the nation's growth when it comes to the management of type 2 diabetes. So I
What
will go
happens
back.
nowadays? What
Yeah.
happens nowadays, Amit? Whenever you go for the CME, a lot of CMEs are happening across the country. Weekend is full of the CME. About 10 to 12 CMEs in one city takes place. But same doctors are being invited in those CMEs. The doctors who are needing the information, those who are working at the primary health care, those who are working at the district hospital, nobody is going to them to invite for those CME. Only people are targeting those doctors who are already knowing everything and prescribing everything. And then same thing happens to the conferences also. Most of the industry houses try to bring those doctors only to the conferences, those who know everything, those who do not need any information, those who already have all the information and those who are practicing in that information. But who will take care of those people, those who are really needing the information? Our
That is my
SSDI had to come forward to find a place that how can we include those people who are really needing the information, who are not knowing about how to handle the diabetes.
That is the capacity building I was talking about.
Right.
Yes,
Of
sir.
lower level.
So, Vijay sir, your thoughts, then Shashank sir, then PV Rao sir, then Rajiv Chawla sir.
Yeah, Amit, the St. Vincent Declaration was a failure. They wanted to reduce amputations, gangrene by 50%, but they failed. So I think RSD should not fail. RSD should join hands and take hold, take control of the district officers, district control officers who are part of the RSDA, and implement the programs like the village adoption program. It shouldn't be a failure like the St. Vincent Declaration. Thank you.
Thank you, sir. Vinod Kumar sir.
No, I have already given the ideas. Just one or two things I just want to tell you, and you already know that there are some unknown factors which cause these complications in diabetics, cardiovascular complications mainly. And we have been talking of all the known factors. But there are factors like, for example, the stress factor. There is I think today you heard 139-year-old cardiac surgeon just collapsed in Chennai. And a lot of doctors who are overworked, they're getting stressed. And many people in the society are getting stressed. And stress is a harbinger of inflammation, oxidative stress, all those things. And this is something, this has to be solved somewhere. Otherwise, this stress is going to take a heavy toll of many inflammatory diseases. So that is one thing which maybe our society takes a notion about it. And about very closely related to stress, I think there is a concept from NHS which is called social prescription. This diabetic people, and for that matter, many other people with different diseases who have, in order to relieve their stress, they are given a, a contact with a social activity, a voluntary activity under a formalized system in NHS. We don't have the formalized system. And if we erect a formalized system, we can ask for social prescription according to the needs of our diabetic patients. There are lots of studies shown that by having social prescription and being happy also reduces HbA1c, and the diabetes is better controlled. In addition to that, their well-being. That is one part. Love, relationship, emotions, stress is the source of all this. That is to be seen. And the other thing is pollution. I think in countries like ours, pollution is a big thing. We should also talk pollution at a policy level. Although the government is doing, can the individual do something extra to have the pollution not harming him? Because today only in television there is a news that in Delhi the air quality is so poor that our age is now less by 8 years. So this pollution is also contributing to diabetes, no doubt about that, and to heart disease, to stroke, to everything. So I think this pollution, stress, and also lastly endocrine disruptors, those which are present in the cans or in the plastic packages, they leach out into the food and we eat these toxic materials. And these toxic materials are a cause of a large number of diseases, one of which happens to be diabetes. So these are the other things. You are on mute. You are
Amit, you're
on.
muted.
Sir, thank you for highlighting these social determinants of the health. They are very, very important. And just you said social prescription. So it is a holistic approach, sir. So we need to think of multiple things together.
Yeah.
And just now, sir, I was just thinking that this is an idea. This paper can be a big backbone, and then we can put it to the public domain. And then we can invite comments from all the members of the RSSDI, other organizations, experts, and then we can build upon this paper that what should be done, and whatever we are missing can also be then incorporated, then can be taken as a document which can be as a long-term project which you can take, or long-term outcome can be determined from the RSSD or any other organization. So PV Rao, sir, your
I would suggest, Amit, I would suggest that you dissect out the sub items and whatever important, and try to distribute those items to the persons concerned who are interested in expanding this document,
right, sir.
and put some ideas, and then a cohesive paper can be produced as a policy paper.
Right, sir. Thank you, sir. Sir, I will first circulate it among this panel, and we will include many other people who couldn't join today because they were traveling and because of some other reasons we approached to them. But we will include each and everyone for their comments, sir.
I think only Sanjay could not attend. Everybody else has
Sir,
come.
we approached to many other people, but they were not available because of some other engagements or the travel. So that is why,
Okay.
sir. Yes. PV Rao, sir, your thoughts and final comments, sir.
We had some experience with school health programs and workplace programs for diabetes prevention and diabetes management. But at least I didn't have much experience with Jan Andolan programs. So if it is done on a mass scale, and I don't know how it can be done, but if you can plan some modalities, make a proper protocol about going into the large number of people and then make it a Jan Andolan. Maybe it is something which we have not tried before. Then Nari Shakti is also something which we have not tried. Women involvement in management of diabetes and prevention of diabetes has not been tried before. So I think these two things have to be looked into in detail, and then protocol has to be formed and try to execute at least on a pilot scale. In some communities, you may have to do it. That is the idea I can put forward to RSSDI. Please look into this matter.
Thank you, sir, very for your insightful thoughts. Shashank, sir, your final words, sir, before we go to the Rajiv Chawla, sir, and before concluding the session, sir.
So I think everybody is on very clear things. See, RSSDI had a therapeutic wheel, and we were discussing mainly treatment modalities, research modalities, and whether it is Ashok Chakra or whether it is Chakra or whether it is a wheel. Let us start a movement on wheels from Kanyakumari to Kashmir, from length and breadth of India. And Anuj, you should take up this as a wheel project and wheel within the wheels. We had one RSSDI chakra, and now we have the chakra of prevention, chakra of screening, chakra of complication prevention, including being mindful of the social determinants, and whether it is from individual level, family, community, or population. And our chakra should be universally applicable. So it should be across social determinants, and it should be simple and easy to implement. And as Dr. P.V. Rao said, that we should pilot it as a project, just like you are doing this village project. We should pilot it as a project, generate some science and evidence, and then you should upscale it across. So I think we have an opportunity, number one, to collate our ideas and synthesize it. Second is then make some short pilots which are scalable at a mass level. And then we should ensure that it is done. And it should be, a role model for the world to follow. Because I think, we are aping. Tomorrow I'm speaking at Dr. Makkar's meeting on ADA guidelines and how we are adapting them for India. This chakra should be a model of care, because the largest population of diabetes on planet Earth is in China or India. It is not in United States. So rather than we following ADA, because they are very structured, they are very evidence-based and science-oriented. So I think it is time for us to generate some good science that they should look up to the RSHDA wheel and look up to the RSHDA chakra, and they should follow our model as a standard of care for their villages, for their prevention, for their therapy. So I think we should start systematically collating and collecting data, do some good pilots. We have opportunity. There are two rate limiting steps. One is, of course, finances, and second, of course, is the will to do this painstaking work. I think the will is there, and I think the finances also will be there for at least pilots, and then, of course, other partners will join. But I think we have a vision which is not just going to be on Zoom calls or on just meetings like this. I think everyone here is so passionate, whether it is Professor Vinod Kumar, who's inspirational to all of us, or PV, who has been a very cornerstone of RSHDI, to Gen Next, which is Amit, Anuj. You know, I think each one of us has a vision, and if we all come together, it is a power. So I think the more we are united, more we are cohesive, the more power we'll have. And we have only one common enemy, which is diabetes. And I think to defeat diabetes, this is it. I think we are in the best of times, as Charles Dickens said, but we are in the worst of times. We are in best of times because we have availability and access of information and vision. But we are in worst of times is because we are having so much of clutter that we are not able to execute it in a very scientific and a systematic way. So I think that gap, if we can bridge, and Anuj, you can make the first step, and Vijay has already been doing this step in his, in feet, in blood pressure, in neuropathy. Vijay has made an impact now. In feet, Save the Feet campaign. Rajiv has made an impact in the space with Dr. Sheshaya group on the woman part, and there is a national GDM day. So I think Anuj, you can take this step forward and take it to the next level. And I think we should all work together as one team, one RSHDI. And I think we should upscale this. But I think we should first collate, synthesize, and we should have two documents. One document, which is a science driven document for healthcare providers, and one white paper for policymakers and stakeholders who are lay people. And both of them will have different yardsticks so that then the influencing power for each one of them can be modeled. And on each of these papers, we should have an actionable model, which is medically actionable, so that we can pilot it and generate evidence so that then others can follow. Thank you.
I think, sir, you have given us a lot of work, and each and every word spoken today on this forum is in itself is showing the path for the better diabetes care in India. So, Rajiv Chawla, sir, over to you.
Yeah, I'm extremely happy that with lot of senior people and visionaries, huge number of ideas have come. But good thing is all of us we are on the common page because our aim is same, our theme is same, our goal is same. That we want to defeat diabetes. So as I said in the beginning, also any number of hands are going to be lesser. All agencies need to join together. All the ideas which we have generated today or discussed today need to be collated. We must partner with various organizations and take government also as one of the agencies because someone very rightly said that all these policies are going to be framed in the center, but they are finally to be executed at regional level, at the state level. And I'm happy that in our days when Shashank, me, Bansi, we were there, we started that rural adoption project. In fact, I am happy that Dr. Anuj is here. He was one of the, again, very active member to get his rural village adopted at Lucknow, which we inaugurated when I was the president. And I know his approach towards community is very, very positive. He's very enthusiastic about taking all these projects at the grassroots level. This is what is actually required with all the agencies, all the brains, all the ideas getting collated. I'm sure together you and Dr. Anuj and other team members in the future are going to take it further down the line and It is, although one of you said that, Dr. Anuj said that it is easily said than done. I agree, it is a very, very tough target. Early days, we were talking of health for all by WHO for everyone by 2000 and 2025. Unfortunately, that couldn't be achieved. Even today, not even one third of our patients are meeting the target of getting HbA1c less than 7. When we talk to combined goal of ABC, at least we want that more than two-third or maybe 75% patient over next 20 years, they meet the target so that we could avoid those complications. As I said, that if we adopt a primordial prevention project at the national level, again, that may be possible that offspring born will not be diabetic, hypertensive, or having obesity or metabolic syndrome. So any pledge today and a right direction and a guidance in the future, I'm sure next 20, 25 years, we can be on the right track, and we may be much better what we are today. Only thing is we need to all join hand together, partner with each other through all agencies, through our organizations, and move in the right direction.
Thank you, Rajiv sir, and it is really inspiring to see so many thoughts coming up on this platform. And you have actually shared each and everything so passionately that I will go back and watch the recording and take each and every word again, and we will collate each and everything as suggested by Shashank sir and share with all of you for your inputs, and we will build it up as a document. But what comes up today after today's discussion, that we are all together and in this fight against diabetes, and each one of us will do whatever it takes, and we will try our level best to make that diabetes doesn't take over in 2047 as a major problem, but we are ahead of the diabetes and we are dealing with this problem. So once again, I would like to thank Dr. Vijay Vishwanathan sir. Thank you sir for your time. You were not keeping well, but still you were here for the entire length of the program. Thank you very much. Dr. Anuj Maheshwari sir, for making this wonderful presentation, coming up with this paper. And Professor Vinod Kumar sir, you are the founder secretary of the RSSDI, a living legend and a lighting guide for each one of us. Thank you very much. Professor PV Rao sir, you have laid the foundation stone for the RSSDI, worked many years together to give direction to the organization, and not just the organization but the overall diabetes care. So your inputs and insights, especially when you endorse the idea of Dr. Shashank Joshi, which is about the Jan Nari Shakti and the Jan Andolan, I think these are the two key words, and I think this is going to resonate very prominently in the coming few days or the few months in the RSSDA, because I can see Anuj Maheshwari sir nodding on these two suggestions by Shashank sir. And Professor Shashank sir, again, thank you so much. And
Whatever Dr. Shashank speaks, that
so,
becomes the slogan.
so I think you should.
So we shall be
So,
repeating
sir,
this slogan multiple times.
so this forum should be repeated at least once a month, so that whatever is spoken on these forum can give shape to the ideas of the future. So thank you sir, thank you
And I think
so much for being there.
it will be worthwhile that when Dr. Anuj you take over in Kochi in the coming 2 months in November in annual conference, we come out with a declaration or a white paper or a consensus which can be subsequently taken across the country through various medias, and we'll be happy to get it published in IJJDC also as a message for the new team that they're pledged to take this health for all patients with diabetes, and in an attempt to reduce NCD and complication over next 25 years. And this is what is going to be a way forward starting today itself. Thank you.
Very,
Thank
very
you.
good idea you have given, sir, and we shall definitely try to work it up.
Thank you, Rajiv sir, and it was really a pleasure to be moderator for this session with so many luminaries of the RSSDI field of the diabetes, endocrinology, my teachers, my mentors, my guides. So thank you once again for joining us today, and thank you all the participants. We will be sharing this paper with you. We will also be inviting your ideas. Please, it is not just it is a work in progress. So each and every idea matters. Contribution by each and every participants who participated today matters. So we will be sending details to you through the IGCP, and we will be collecting the data. Thank you very much.
I think most of the participants today, they would be in Makar's conference on either day one or day two, isn't it?
Sir, there are 12,000 RSSDI members, sir, and more than 20,000 physicians practicing diabetes in India. So I think there must be few hundreds who listen to this conversation today.
Good, good. So, Amit, you will be there the day after tomorrow.
Yes, yes. Thank you, sir. Thank you.
Okay,
Thank you.
Good night,
Thanks, sir.
everyone.